Good morning. Good morning, everyone. It's Dr. Jess Daigle here for Hot Topics Tuesday. So let me go ahead and get this going so we can have our talk today. All righty. Okay, so November is Prematurity Awareness Month. And if you've been following me, you know that I have had two of my own preterm infants. One was born at 31 weeks, and the other was born at 36 weeks. My son, who was born at 31 weeks, had to stay in the NICU for about 5 weeks. My daughter was 36 weeks. She was able to come home, but we still had to deal with challenges regarding jaundice and feeding. So for my Hot Topics Tuesday today, I want to talk about what is the NICU, the NICU, because many babies actually end up going into the NICU. And so I thought this would be a good opportunity to talk a little bit about what is the NICU. So the NICU stands for Neonatal Intensive Care Unit, okay? So this is a place in the hospital where babies will go directly after birth if they need medical care. So if the baby is having trouble breathing after birth, if the baby is born early, if any reason we're concerned about the health and well-being of the baby, the Neonatal Intensive Care Unit, or NICU, is where they would go to get further testing and further care. There are different levels to NICUs, okay? So there's levels 1 to 4. So 1 is your typical newborn nursery, where just routine things are happening, usually at minimum, a little bit of observation. If the baby is breathing a little fast right after birth, going through transition, but overall it's going to do well and does not need support for it, just maybe 1 or 2 hours of monitoring. There's level 2, which can take up to babies born after 32 weeks up to term. And level 3 and 4 are for higher acuity babies. So definitely any preterm infant can be in a level 3 or 4 NICU, depending on the amount of care they need. If they need more one-on-one intensive care, then that's where they go, and up to surgery. So it can be a premature or term infants who are sick in some way. So a lot of people assume that the neonatal intensive care unit is just for premature infants, but a term infant who is having any health challenges can go as well. But the most common reason for admission is prematurity, which is an infant under 37 weeks gestation. So who gets admitted to the NICU? Those at high risk include premature infants, newborns less than 37 weeks. So these infants are not as physically and developmentally developed. So everything, when I admit a family to the NICU, I explain to them everything when they're premature is early. So the weeks of life does matter. There are different things that are happening as the baby grows inside of the mother in order to strengthen each organ system and allow it to function at its capacity. So preterm infants have a harder time transitioning to the outside world compared to full-term infants. And this is because everything is still young and growing. A lot of times when they're smaller, they don't have enough of what we call brown fat, which is a type of fat in our skin that actually insulates a little bit more and helps us maintain our temperature. So babies who are born a little bit earlier, depending on the gestational age, may not have enough of this. And so they struggle with their temperature control. Other things like their vitals being unstable, so rapid breathing or slower breathing if they've been impacted by the mom's medications, having issues controlling their glucose because their metabolism is also still developing and trying to function properly. Breathing issues is the #1 common thing because the lungs are still developing. The lungs produce a substance called surfactant, which helps us breathe easily. We all make this, and that helps us to breathe in and out instead of all day, okay? And so a preterm infant will not have made enough of that substance in their bodies yet, so they will have trouble breathing. And then eating and growing. So babies develop swallowing, sucking, breathing coordination around 34 weeks gestation on average, 33 to 34 weeks gestation. So imagine a baby born before that time will not have the instinct to really suck yet because it's not something they would have been required to do. So they will often have times a hard time eating and have to get nutrition innerally from a tube going through their mouth and no directly into their stomach, or via nutrition via the IV in their hand or through the umbilical cord. But eating and growing are challenging for preterm infants. And so this is why they need the NICU, because we have to kind of emulate what would have been happening inside of mom, which your nutrients through the placenta would help the baby to grow and develop. And so now we're tasked with getting this done external to the mom in the NICU. Who else gets admitted to the NICU? Like I said, full-term infants who also have health challenges. So a full-term infant can still have some problems with breathing. Babies have fluid in their lung inside of mom. So this is all babies. And so then when they're born, there's some transitioning that has to happen down even to the cellular level to remove that fluid out of the lungs and allow the air to expand. So that's even why we like them to cry when they're born. They're taking in air, helping to expand those lungs, okay? And so a full-term infant can still have trouble with that. Like more C-section babies will have more of a harder time transitioning that fluid out of their lungs than compared to vaginal births, but it's not 100%. It's just more likely. They also can have breathing problems if a mom is like diabetic. There's been some research that shows that some of those babies born to moms who have had issues with glucose control, sugar control, which is a part of diabetes, they had this problem with that. And so that they've shown that inactivates that surfactant I was telling you about. So if surfactant is designed to help you breathe easier and you're not functioning well with that, then that means you'll have trouble breathing. And so some full-term infants can have some breathing issues for that. If you're having defects in other organ systems, so unfortunately, babies can be born with anomalies to their organ system. So there can be defects in the heart, the brain, even the spine. I've had some babies with the spine born outside of the spinal canal. So like actually above the level of the skin of the back where you can see it. Kidney issues, every organ system, just about, if there's any problems with it, genetics, any genetic syndromes, depending on the syndrome, can present with some health challenges right away. And these babies need care in the NICU. Infection is also another reason that a baby will be admitted to the NICU. So sometimes babies can have infections that are transferred over from the mom, things like HIV, syphilis, or even just group B strep, which is a normal bacteria that moms house that don't really cause problems per se. I mean, they can get chorioamnionitis from it, so infection of the placenta and the fluid around it, but which some of that bacteria can pass on to the babies as well. So this is why we're really want moms to get prenatal care, so these types of things can be picked up on and observed ahead of time so you can get the care that you need to help you and the baby. And then sometimes there have been traumatic deliveries. So vaginal delivery, the baby getting stuck, or even or just even problems getting out at delivery, or something happening inside with the umbilical cord, being wrapped around the baby's neck, or if it prolapses outside of the vagina, just different things where that can impact the oxygen delivery to the baby. Oxygen, as you know, is what gets our tissues and our cells working and helps our organs and our whole body to function. And so if we're having problems with getting oxygen, then that causes cellular death, which can cause problems. So this is a reason a baby might be admitted to the NICU as well for further care. So what happens in the NICU, right? Like when your baby goes to the NICU, what are we doing in there? So you have a care team that is going to work to get your baby better. And the care team can vary in many NICUs, okay? So at baseline, you will have to have a doctor and a nurse at minimum, and pharmacy that is capable of providing the medications that's needed, and lab, things like that. But some places have more core members of the team, like a dietitian or physical therapist, speech therapist, occupational therapist. people designed to also focus on the development of the baby. And so that depends on the type of NICU and the level of care, because the more premature babies will need a little bit more of those services right away, maybe compared to a term baby who may just be in the NICU for glucose control and it's going to get out of there in like 3 days or so. So when a baby is admitted, they're assigned a bed. Okay, so that can look like a radiant warmer, which is an open little square space that has heat control, where the nurses can visibly see the baby, and they can be hooked up to the monitors as well that are going to monitor their heart rate, their respirations, and their oxygen level. So whenever a mom is admitted, a family is admitted, the baby is admitted to the NICU, excuse me, I talk with the family, I walk them through all the leads from head to toe, anything that is on the baby and what it is doing. And this is so important to help families kind of acclimate to what we're really doing for the baby at the bedside. And some babies might even have to be in an enclosed box called isolate. So I called it like the external room. Okay. So you're almost trying to recreate that environment that is inside of mom in terms of like that quiet, that warmth, that isolation, so to speak, to allow the babies the time to develop and grow, especially the smaller they are. So we typically tend to put babies, almost all babies under 30 weeks, most likely will go in there, but some, it really depends on the weight. So most babies under like 1,500 grams will go under there, which is a little bit under 4 pounds. My son was 1,765 grams when he was born. And so that's like 3 pounds, 15 ounces. And so he was in the isolate over time, but this was like 9 years ago. So we've kind of gotten a little bit more lenient in terms of leaving them in the radiant warmers, but we're really looking at, are they losing a lot of weight from burning energy to stay warm? So that's important because babies preterm infants can lose water. Like all babies are losing water anyway. So even a term baby, we expect to have some weight loss from water losses. That's normal, but we don't want too much water loss in a preterm infant. So what else happens in NICU? Like I said, that care team is there. And so the unit can have open bay, meaning when you walk in, you see all these little radiant warmers kind of lined up that may be divided by a curtain to allow privacy when a family is visiting. And some NICUs are more fortunate enough to have private rooms. So it's like actually like room with a bed for the baby, the open bed or the isolate in there, and a space for the family to sleep as well. And so again, that depends on the hospital. So not all hospitals have the same capabilities, as I'm sure you know. And so it really depends on where you have your baby, what they have access to. So like I explained earlier, the care team is comprised of physicians, advanced providers, core members, and other specialists. So your physicians will be your neonatologists, which are pediatricians that get 3 years additional of training, just focused on sick newborns. Then pediatricians like myself, I'll work in there in the NICU as well, along either by myself or with a neonatologist, depending again on the level of care of the hospital, but always have remote access to a neonatologist at a transferring center. So like if I had a baby born at a level 2 NICU that was like 26 weeks, I'm going to get that baby stabilized, get everything done, but I'm planning to transfer that baby to a level 3 or level 4 NICU. Because that baby needs more one-on-one care, and the nurses have different skill levels at those hospitals too. A neonatal fellow, which is a neonatologist in training. So it's kind of like the resident of the neonatology program, like a pediatric resident would be a resident for to become a pediatrician, full-blown pediatrician. Advanced providers, so neonatal nurse practitioners, which are nurses with advanced degrees that focus on working in the NICU. And physician assistants also can be seen in some NICUs. Core members are your nurses. So there are neonatal nurses often. Again, nurses who focus on that. Respiratory therapists, neonatal dietitians, pharmacists, speech therapists, occupational therapists, and physical therapists. So speech therapists obviously working on feeding and oral motor skills, occupational therapists working on like the environment and how they relate sensory things, and physical therapy working on the strengthening of their body. And some of these have some overlap, but as your baby is monitored in the NICU and develops, we're assessing their developmental milestones. which, we always adjust the age of the baby. So if they're born 2 months early, we adjust their development by that much. So what they would be doing at 2 months, if they were born on time, we don't expect them to do it until they're really chronologically 4 months of age. And if you have questions about that, you can always drop a question in the comment section and we can talk about it. Other specialists can be involved depending on the needs of the baby. So if they have heart problems, murmur, problems with oxygenation, we hear, concerned about a defect or anomaly that may have been seen prenatally on ultrasound, we're consulting cardiology. If they need surgery for any reason, bowel issues, hernias, things like this. Hernias can tend to be a little bit later. That's usually not emergency surgery, but anything with the bowel obstruction, anything like that, may require even cardiothoracic surgery. Sometimes we need to be done on some of those heart defects. Things have to happen right away so the baby will live. So with things like surgery, they gauge the urgency of the health condition because you want your baby to be as old as possible when they get a certain surgery, just because they do better with things like anesthesia. But obviously, you're not going to sacrifice the overall health. It's risk benefit type thing. If the surgery is life-saving in that moment, then that's what they're going to get. Neurologists, so if there's any issues with the brain or seizures or things like that, nephrologists for kidneys, geneticists, like I said, if there's any syndromes that is apparent or concerning on admission or after birth, they will be often consulted and more. So it really just depends. Whatever health condition there's concern for, we're reaching out to a pediatric specialist in that area to assist us in caring for the baby. So the care team around daily, or they should be. So every day you should have an idea of the plan for your baby. And sometimes I can tell you this, the plan is really the same. It's just that it's developing. So if your baby is born early, the plan is always for them to grow, right? It's just going to take time for them to grow. And I know some families I've seen in a group I'm in, where some families can be a little bit frustrated by, the team being like, well, we're just taking it one day at a time, or, they're just growing, but it's true. Or, remember that the baby would not have been there yet. And I do remind families that, but more as an encouraging, because sometimes we're putting unrealistic expectations on ourselves and our babies, and it's making us frustrated because it's not something we can change until it changes, meaning the baby has to take time growing just like they would have had to inside. That same process still has to happen. You're just being witness to it on the outside. So it's really meant to be encouraging when someone is telling you that, but I can definitely see how it can be frustrating because you just want your baby to be well and at home. So the care team rounds daily, deciding on weaning okay, is the baby ready to come off oxygen today, off respiratory support, or do we need to change the type of support? Okay, they were on a ventilator, meaning they were intubated with a tube going down to their lungs because they needed help breathing. Now they're breathing more easily on their own, still need a little bit of support though. They're capable of breathing on their own, but still need a little bit of support. They might go to CPAP or to a basic cannula. And so the team will decide based on what your baby looks like when they're breathing and what their oxygen level is doing, and sometimes what their chest x-ray may look like as well. Increasing feedings. So every day, trying to increase the amount they're taking. So even if they're not able to swallow because they're young, we can still provide them nutrition through the IV, as I mentioned earlier, or through a tube called a nasal or oral gastric tube, oral, mouth, nasal, nose, gastric. So a tube going from the mouth and nose to the stomach directly, and we can use a pump to provide the feeding. Ideally breast milk. So I do encourage my moms, if you have a baby that is being admitted to the NICU, and even if you had no intention of breastfeeding, I encourage you strongly to do it at least while your baby's in the NICU, because breast milk has been shown to be more superior in helping preterm infants with growth and brain development and even health of their organs. And so nothing's 100%, but you're much more likely to have a baby do well on breast milk. And so as soon as you have your baby, if you're born early, within 6 hours, you need to start pumping. And so keep that in mind, or if you're watching this and know somebody who's maybe have been threatening early labor, or there's some idea that they're gonna have their baby early based on some prenatal stuff, have them already start reaching out to a lactation consultant that can help them, somebody who's well-versed in feeding, breastfeeding a preterm infant especially. And also advocate for your right to put the baby on the breast once they're old enough. So if your baby's admitted in the NICU, and you're learning about this environment and the team, just say, hey, whenever my baby is oral modally ready, I would like to start letting them learn to eat at the breast. And a lot of it is you want them to maintain their stamina. So even if they do a 5 or 10 minutes, it's still better than nothing once they're at that place where they're sucking, swallowing, and breathing without distress. Okay, but the goal is for us to get your baby home to you in your best health, in their best health. So that leads to the next point. So when is the baby ready to go home? So I get this question all the time as soon as they're admitted, once they've kind of just heard a little bit about why they're being admitted to the NICU. That is the next question, along with when can the baby get circumcised? I get that one too. That's like the number 2 question, especially if it's a boy. But this is the main question, and the answer is it will vary. But what the baby needs to do to go home most likely won't change. And so that's what I've started to explain to families, because it's hard to give an exact date, because it's more about the skills, the skill readiness for a baby when they go home. So a NICU journey, especially for an extremely premature infant, an infant under 32 weeks, 30 weeks, can be long, and sometimes it's steps forward and steps back. So if you've ever had a family or a friend that have a baby in the NICU, just ask them a little bit about their experience. And I'm sure you'll hear this, that, there'll be moments where it looks like things are going well, and then there's like a little bit of a setback. And a lot of that has to do with the fact that the baby is developing and growing, and it is challenging. We're trying to recreate a process that would have happened inside. So obviously that's not going to be perfect, as if you could have naturally grown your own baby inside of you with your nutrients from you through the placenta, and they're allowed to rest and they don't have too much stimulation from the external environment. So we do our best to create that type of environment in the NICU, but it's a lot of other babies in the NICU. It's nurses running around, it's therapists, it's things happening, dings, monitors dinging. And so a lot of that can impact like the baby's NICU journey, but we're doing the best we can to help you have a live and as healthy as possible baby. So in general, though, the goal is for the baby to be off any type of breathing support. So you ideally want your baby going home breathing on their own, able to maintain their body temperature in the open crib, because when they go home with you, they'll be, should be sleeping on their back in their own sleeping space. Tolerating feedings by mouth, so either eating directly at the breast or eating from a bottle, not dropping their oxygen or their heart rate when they are eating. So all of these things you want ideally to be well or at their maximum when they're going home, and also growing. So you want to know whatever we're feeding the baby is helping them to grow. And ideally you want them to be growing on average an ounce a day when they're on what we call like full feed. So we do math to calculate based on just research, ideal calories that's necessary to help your baby grow and the type of nutrients they need. And sometimes we have to add something called a fortifier that has extra like things like calcium and phosphorus to the breast milk for say, or if there's formula that's fortified with these other things that's higher calorie to give your baby that extra that they need to grow properly. And also, can they safely go home in a car seat? So preterm babies are often given what's called a car seat test. So that's when we put them in the car seat that they'll go home in, and we watch them on a monitor minimum 90 minutes or so to see are their vitals compromised? Do they drop their heart rate? Do they drop their oxygen? And have any issues with their breathing, to help us decide if they're ready to go home and will be safe in the car seat as well. So thank you so much for watching this talk. I know it was a lot of information. If you have questions, feel free to pop them in the comments. Definitely share this video, like and share it with a family who either their baby is just recently admitted to the NICU, or even if they have one in the NICU and they may just kind of still be a little bit lost about what's happening in the NICU. This is definitely sure to help them. I also do some consultations. So if you want to ask questions about your NICU experience so far, just get a little bit of an extra opinion or some guidance, you can definitely head to my site here and sign up for a meet and greet with me. And I can see if there's any way that I can help you or point you in the right direction. Again, I'm Dr. Daigle of Mom and Me MD here in Atlanta, Georgia, an in-home and virtual concierge practice. And remember, this is just education and overview, just an overview. If you have specific questions, know you always have the right to talk to your healthcare provider for any concerns you have about your baby. You are your baby's best advocate. I hope you have a great day and hope you join me next week for my next Hot Topics Tuesday. Bye.